Hi everybody. Sorry I haven't posted videos. More technological issues than anything. I still haven't figured out how to speak over 14 minutes and 59 seconds and it still be able to upload and not give me some kind of pushback. I don't get it. I don't know why it won't thoroughly upload my content if it's literally anything more than 15 minutes long. It's driving me nuts. I don't understand it, but it's really pissing me off. The other thing is there's like a space issue. If I record more than one video in one day, my computer is like, you don't have space for this or whatever. And I'm like, and I don't know why I don't have enough space for this. And it's something with the OneDrive. And it's like, why can't things be simple? Like, can we go back to floppy disks? Would love a good floppy disk, right? We just store things on the computer. But it's like, no, it's in the bubble world thing. I don't get it. I don't get it. And I'm just going to pray that this works out. So this video is just to highlight or to give you some additional feedback regarding the midterm and what I was looking for, which for the most part you all really did great. I don't think anyone got less than an 80 on that, and maybe even an 85, I believe. So so that was really good. So what I want to do is just kind of take a minute to look at the information. Hold on one second. Just to take a look at what the content was. If I can bring it up properly, this thing is being weird. Sorry. Okay. So we have this patient, her name is Sarah, she's 33, feels like she's being forced into treatment, DCF involved, using heroin, history of doing Xanax and cocaine. So there's a lot in here, multiple children, same father, which is kind of a strength, which is good, but just like a lot of stuff to unpack here. And just to be clear, this is a fictional character, however, not completely unheard of what we would typically see. This person actually represents probably the majority of the DCF style cases that I've dealt with. So just to throw it out there, so for Dimension 1, acute intoxication and potential withdrawal. So here in this case study, it doesn't know any history of withdrawal symptoms, but from what we know of use regarding opiates, Xanax, alcohol, cocaine, things along that line, there is an increased risk for withdrawal. Now, some of you had recommended that she needs to go to detox. Here's the thing. If a patient is pregnant and they are on methadone, you cannot detox them from methadone. Now, some people say that there was a program at STAR at one point, I think it was called Starbirth or whatever, where they said that they detox clients off of methadone. I think that's possible if the methadone dosage is really low or the use is really low. But for the most part, it's not recommended because the fetus can go through withdrawals and potentially die. So the common practice is if a pregnant woman is on opiates that you want to get them on some type of maintenance therapy. Typically, it's going to be either methadone or it's going to be Subutex. Okay, not Suboxone, although some providers have given Suboxone in the past if a client is allergic to Subutex. So that's essentially what you're looking for in that particular spot. In Dimension 2, the only thing medically she has going on is that she's pregnant. It does say that she's expecting in the summer. So if you're putting that towards current time frame, that puts her out what, like 3 months pregnant or something like that? I don't know. I'm absolutely horrible at math. For emotional, behavioral, cognitive conditions, it doesn't have to be negative. Some of you had ruled out possible PTSD, which could be in there, especially just from some of her treatments as a child. Excuse me, I apologize. A client told me today that when you yawn, you're purging yourself of like negative energy and stuff. I yawn all goddamn day, so I must have a lot of stuff going on in here. So sorry, where was I? So she, cognitively, she seems to be very intelligent, graduated at the top of her class, has good artistic abilities, and has been motivated in the past. So that's good. It clearly seems that she has some issues regarding her parents and stuff like that. Does she have depression? Does she have anxiety? You could potentially rule those things out, but I don't recall mentioning anything significantly that identified as such, but it wouldn't be uncommon, for someone to have those, especially as it relates to essentially what she's, been involved in, not just with, the domestic violence with her significant other, but just issues with her parents and, just kind of being told that she was like a problem child and stuff. And typically in these situations, I'm sorry, I just have to put my thing on just real quick. Sorry, the wind is making my things go. So she is motivated in that sense. So you can definitely add that into the emotional, behavioral, cognitive stuff. You can also know, potential conflict with family members that could lead to, other barriers. Readiness to change, I would put her in preparation. Some of you had said contemplation. Some of you had said action. It really is kind of in the middle between the two with preparation. And the reason why is because she's aware that she's got something going on. She's willing to do something about it, but there's still some barriers being put in place. So she's not fully in action because she's been kind of given this push to do services because of her parents. So I would put it around that sense. All right. Relapse, continued use potential, very high risk, using while pregnant, has a tendency to glorify some of the use in the past, saying that she's used coke as like a pick me up. And, she was really into like the drinking and the clubbing scene and things like that. The fact that some of her use has continued despite some of these other consequences that have happened. Her parents already have custody of her children. They're threatening to take this one as well. She continues to engage in this kind of behavior. She's engaged in some high-risk behaviors, especially as they relate to, the prostitution in order to procure drugs. So the relapse here and the relapse potential is really, really high. And it seems like environmental issues may also influence that, and just not feeling like she's connected and has a whole lot of support, especially with family. Living environment, it doesn't identify that she's living anywhere in particular. Purging. It doesn't identify that there's anyone in particular that she's living with. So it sounds like she's kind of couch surfing at this point, but all of you are really good in noting that that information was missing from this and that it needs further investigation. But for the most part, most of you also recommended that she would benefit from some kind of residential program or some kind of family involved program as well, which is great. Okay, recommended level of care should be really, really brief. Something like medical evaluation, appointment with an OBGYN, individual counseling, referral for inpatient services, AA meetings, like real brief, simple stuff. The summary itself is where you should be specific. And at this point, this client really would be diagnosed with an opiate use disorder severe and should also include a stimulant use disorder, at least mild, just because of her use in the past. And the same thing with the benzos. Now, it says that it was at least a year or more prior. So that means she could potentially be in early or full remission. So it's something to keep in mind. But the big primary diagnosis here would definitely be opiate use disorder severe, and we're going to get into that. So opiate use disorder severe, self-referred to treatment, strongly encouraged to treatment by her family, who's threatening to take custody of her child after she gives birth because of her continued use while being on methadone maintenance. Client has not been compliant with the methadone program as evidenced through her continued use. There's children coming right now. Monsters are here, as evidenced through her continued use. Also, I got distracted. You can note her strengths, that she is artistic, that she has desire to have her children involved in her life. But also note that it seems like she needs some sober supports, that she could benefit from some, engagement with her family in her treatment, and, just getting involved in some kind of a community-based program. So, for example, AA and NA would be great. Being involved in the Women's Center would be great. Individual counseling would be great. So all of these services would be really, really useful and helpful for this particular client. So you would finish this with adding your recommendations. Client recommended to IOP, inpatient, whatever it may be at that point. Okay. So moving forward with the questions, okay, so provide an appropriate clinical diagnosis for this client and identify information from the case that matches criteria to support the level of diagnosis. So I would diagnose this person with an opiate use disorder severe diagnosis, and you can rule out the other diagnoses as you continue further with assessment and treatment of this person. Now, the information that I would look at would be continued use despite consequences, using in physically hazardous situations. So not just using, but also engaging in behaviors that are dangerous, like the prostitution. Clearly, she has a high tolerance and also high risk for potential for withdrawal symptoms, especially if she's using other substances in order to kind of perk her up and to kind of get her day going. Continued use despite physical and mental health issues that come along with it. Seems like she's got that resentment going on. She's at a higher risk of having these relationship conflicts and these relationship issues. Clearly, there's something significant going on in terms of her, her insecurities, which is why she continues with the relationship with someone who, treats her so poorly, but yet continues on, thriving or desiring that relationship. Trying to think off the top of my head as well. Cravings clearly are there if she is prostituting herself in order to get the drugs that she needs. That's at least 6 off the top of my head. So you get the point. So those are the things that you want to highlight. Those are the things you want to take a real close look at, because it's not uncommon for someone to really question your clinical judgment on this. 3 things that stand out in the cases. You all did really good on that and highlighting those different areas. Parents were one, Vinny was another one, the DCF involvement, the prostitution, all of that. Strengths that could support Sarah's recovery. She is very, very artistic. She seems to be very bright. She's very forthcoming with information in a pretty clear way. So it sounds like she's wanting to share this stuff and wanting to get help for it as well. 3 barriers that can get in the way is definitely Vinny. That's going to be a big issue. The other thing is going to be her parents. A couple of you noted that she seems to be acting in spite of her parents, which is definitely something to take a look at. So she's going to need a lot of motivational interviewing services, or a lot of motivational interviewing techniques in order to really kind of get into this. Family involvement. How can you encourage her family to be involved in her treatment? Things like Al-Anon, family meetings. STAR has the RISE program that's really good at helping with family interventions, and just letting her dictate how she wants her parents to be most helpful to her. And I've mentioned that a lot in the past too. Identify 3 local community referrals. Some of you came up with some really, really good stuff, highlighting things like the Women's Center, High Point. Sorry, my head is like wicked itchy. High Point. What else? Access to AA, NA meetings, PACA. Also with the medical need because of her pregnancy is really big too. And then the rest are pretty self-explanatory. I mentioned the preparation for stages of change. You guys gave me really good feedback, and yeah, good work.